Hello everyone, welcome to HIM 216. This is the fourth and last lecture covering Chapter 2. In your textbook, if you will, please turn to page 39. And this part of the chapter basically talks about how you start the coding process when you're coding from when you're coding with a medical record. And it tells you that most coders, and we're talking about inpatient records, most coders start by reading the discharge summary if they have one. If they don't have one, they can start with the ER record. They can look at the history and physical. Then they're going to look at physician documentation, meaning that you look at the progress notes, you look at the physician order forms. If there are any consultation reports, you read those. If the patient had surgery, you're going to be looking at the operative report. You're going to be looking at the anesthesiologist's evaluation of the patient. When we're coding, we're looking at the documentation to determine the principal diagnosis, and we have talked about what that definition is. We don't only code from a physician discharge summary because physicians aren't required to know what the coding guidelines are. They aren't required to know what the definition of a principal diagnosis is. And while the discharge summary should cover the admission for the patient, they may not always list all of the diagnoses that we are going to code, and they certainly may not list them in the order that we will list them when we actually do the final coding. We can certainly look at lab reports, radiology reports, EKGs, any ancillary reports, pathology reports, but we're going to make sure that any documentation in those reports is validated by the attending physician. So for instance, if you have a pathology report that shows that a patient has lung cancer, and in fact the physician has only documented that the patient had a lung mass, then you're going to obtain additional information in order to completely code that. Now on page 39, I want to look at these examples with you. In this first example, the ER form has some common medical conditions listed, and the physicians can actually check or choose which of those they feel is pertinent. And the ER physician circled end-stage renal disease, ERSD. But as you're looking through that medical record, there is no documentation of end-stage renal disease. There's no documentation the patient's on dialysis or has ever received dialysis, and patients who are have end-stage renal disease definitely receive dialysis. It doesn't say that the patient's waiting for a kidney transplant. The only documentation in that chart is for chronic renal insufficiency, and there's a difference in the way that you actually code those. N18.6 is actually a major complication comorbidity, N19.9 is not. And so the challenge with this is, are we going to code the end-stage renal disease without attending physician cooperation? And no, we are not. That's a huge diagnosis to add to a chart without supporting documentation. And the next example, you're looking at the patient's inpatient chart, and it says that the patient has a history of pneumonia. It's also in the past medical history. They didn't perform a chest x-ray on this patient. The physical exam said that the lungs were clear, but on the discharge summary, pneumonia is documented instead of history of pneumonia. And the difference in coding is J18.9 versus Z87.01. Coding the pneumonia means you're saying the patient right now has pneumonia. And that is not supported in the medical record at all. You could generate a query and ask the physician for clarification, or you could actually code the history of pneumonia for this patient. And actually, if I were coding, I'd code the history of pneumonia because clearly the patient doesn't actually have pneumonia. But you could generate a query if there were any question about it. In the next example, the patient throughout the chart, the patient's documenting as having ESLD, end-stage liver disease. This is documented as well as the fact that the patient's waiting for a liver transplant. The patient has a history of cirrhosis and hepatitis C. But there's a progress note that says cirrhosis, hep C, ESKD. Well, ESKD is end-stage kidney disease, and this is probably just an error on the physician's part. There's no documentation in the chart that shows anything to do with kidney function, and so this is probably just an error on the part of the physician. And again, I would generate a query and give the physician an opportunity to clarify this or to amend the medical record. We can actually code from any documentation provided by a physician, and it's important to know who physicians are and who they are not. A physician can be an attending physician, it can be a consulting physician, an intern or a resident, surgeons, anesthesiologists, oncologists, internists, hospitalists, intensivists, family practitioners, interventionalists. Medical students are not doctors yet. They're not licensed. They haven't completed their education, they haven't taken their state boards, and they are not included in the category of physicians. In many hospitals, nurse practitioners and PAs also have documenting authority, and they will document in the medical records. Now, in your book on page 40, it tells you in that first paragraph that you cannot assign codes from radiology reports or pathology reports or lab reports without obtaining documentation from the attending physician. And this is the example of the mass in the lung. And however, if you have a physician that documents, for instance, in your book it gives you an example of a fracture of the ulna, and the radiology report gives you specific information about that fractured ulna that you can code, that is perfectly appropriate to do. So when the ancillary reports provide additional specificity for a condition the physician has documented, then you can code it. Now we're going to talk about the query process. And queries have been around for some time. Queries are documents that actually are approved by the medical staff. When a query is generated, it becomes a part of the official medical record. There are different reasons that queries are generated. They usually relate to physician documentation. If there's anything excuse me, ambiguous or unclear, a query can be generated. They can help improve physician documentation. They can give the coders the information they need to assign a specific code. The purpose of a query is not to improve reimbursement, it's to improve documentation and also to ensure data integrity. We want the most complete information that we can obtain in order to code very accurately. Now, in your textbook, there is the section that talks about the use of queries in the coding process. However, we have a new query guide that just came out in May of 2017. And I have actually added that query guide in course content in your course. And this is an excellent tool that I want you to take a look at. We'll actually be using this query tool and going over it more in future courses when you have a better understanding of coding, and we'll talk about when we're going to query. But AHIMA just published this, and actually you have access to this information through your AHIMA membership. When you log into AHIMA, you pick the body of knowledge, and then you search on Query Toolkit, and it will take you to this most current toolkit that AHIMA has published. And I'm not going to go over this in great detail, but this tool talks about the reason for coding, for generating queries. It's very important to coders. It's very important in the clinical documentation improvement process. The medical staff should be very aware of the querying, and it's also a process that is supported by the cooperating parties that are responsible for ICD-10, CM, and PCS coding guidelines. This is a great tool that talks about when to query, and there are all types of situations when it's going to be appropriate to generate a query, and those are listed here for you. I'm not going to go over these in great detail. I'm not going to read them to you. These are very similar, if not the same, as the ones that you have in your textbook. And then it talks about the query process. And when we're generating a query, it can either be concurrent, meaning while the patient is still in the hospital, or it can be retrospective. If it's concurrent, it's usually done by the clinical documentation improvement folks, or it's maybe a concurrent coder. But retrospectively, it's typically coding that is generating that query. Queries can be written, they can be emailed. When we're looking at the query templates that are provided here, they can be edited so that if there's any part of the query that's not pertinent, you can delete it, and then you can also add pertinent clinical findings. Queries can be verbal, they can be over the phone, and in that case they will have to follow all the same guidelines as a written query. And then this talks about the format of queries. They have to be very clear, they have to be concise, they have to be non-leading, they should be simple, and they should be direct. Your queries should include all the patient's identifying information, and queries need to be logged. You should keep track of all the queries that are generated so that you can see if you have a coder generating queries for a certain disease process, if you have a physician who consistently has documentation issues, if you have an area that's problematic to multiple coders. So there are very good reasons to track and trend queries so that you can see what's going on with your process. There are instructions here on actually how to generate the query and use the templates that are included in this toolkit. That's not something that you'll be doing this semester, but the information is certainly here, and you can review it. And then the toolkit does have sample queries that we can use, and you can take your time to go through these. There are generic templates, and then there is a present on admission template, and let's see, there should be two: present on admission, and then we have, and then after these general queries, here's a cause and effect relationship query. My mouse Adobe's not cooperating very well for me for some reason. I apologize for that. Cause and effect relationship. Then the queries are broken down based on the chapter in ICD-10. Now, not the chapter in our textbook, but the actual chapters in the ICD-10 codebook. And you'll become very familiar with those over the next week as we begin going into and looking at that codebook. So anyway, these go through the different chapters that are in ICD-10. So I wanted to share this tool with you, show you where it was in the course, so that you would have an option to actually go into that tool. Now, your question for this lecture is, you're looking at a chart, and when you're looking at the lab work, there is a hematocrit of 28 reported on the lab work. The patient wasn't treated. The lab work was never repeated. The physician does not address it. The first question is, are you going to code this low hematocrit? And then the second question is, would you generate a query for the physician asking him about the low hematocrit? And that will conclude this final lecture for Chapter 2. Please let me know if you have any questions.